Distinguished guests, ladies and gentlemen, good afternoon and welcome to Queen's University Belfast. As the Acting President and Vice-Chancellor here at Queen's, I'm delighted to welcome you all here today for this celebration of the 70th anniversary of the NHS, which we are hosting in partnership with the Department of Health. I wish to extend a special welcome to our guest speaker, Professor Rafael Bengoa. We are honoured to welcome you here today and very much look forward to your lecture. A lot has changed in healthcare delivery over the past 70 years, and indeed we have now come full circle with a greater focus on disease prevention and delivery of services within primary care. To keep abreast of the changing environment, the Centre for Medical Education in the School of Medicine, Dentistry and Biomedical Sciences at Queen's is currently undertaking a major review of the undergraduate medical curriculum. In undertaking this latter review, we are very cognizant of the much-needed transformation of healthcare delivery systems, which have been highlighted in the Bengoa report, authored by our guest speaker, entitled Systems, Not Structures, Changing Health and Social Care. We are being supported in the curriculum review by Professor Val Waz, former Dean of the Keele Medical School and author of the 2016 report, By Choice, Not by Chance, which provides potential solutions to the current recruitment challenges which we have at the present time in general practice. We are delighted that Val has been able to join us today. Again, Val, I can't see you just where you're sitting. Yeah, up here again. Val, you're very welcome. Medicine has been a keystone subject at this university since its foundation, and we have a very proud heritage of world-class medical education and research. Medicine has been taught in Belfast since 1821, and there has been a medical school at Queen's since 1849. At times like this, it is only right to reflect on some of the remarkable figures who have brought distinction to Queen's and to Northern Ireland over the past 170 years of the existence of our medical school. Time allows only to mention a few. First, I would like to mention Sir William Whitla, who symbolises what can be achieved by determination and a hunger to learn and to succeed. From modest beginnings as an apothecary's apprentice from County Monaghan, he went on to be an extraordinary leader at the forefront of medical, academic and civic life. The Whitla Hall and the Whitla Medical Building are reminders of his unique contributions to Queen's University. I think too of other famous men and women like Professor Molly McGeown, a pioneer in renal transplantation, and Professor Frank Pantridge, who was the father of the mobile defibrillator, which has saved hundreds of thousands of lives across the world since 1965. I also think of the late Professor Patrick Johnston, our former President and Vice-Chancellor, former Dean of the School of Medicine, Dentistry and Biomedical Sciences, and world-leading cancer researcher. Paddy, along with colleagues from across the faculty and the Health Service, won the Queen Elizabeth II Diamond Jubilee Anniversary Award for the Northern Ireland Comprehensive Cancer Services Programme, which led to a marked reduction in cancer mortality rates here in Northern Ireland. We are incredibly proud of the legacy left by these and many others from Queen's University who have had such a lasting impact on healthcare here and around the world. That brings me nicely to our guest speaker today, Professor Rafael Bengoa. Professor Bengoa served as Minister for Health and Consumer Affairs in the Basque government from 2009 to 2012. Professor Bengoa practiced as a doctor for 7 years in both hospital and primary care. He also worked for over 15 years for the World Health Organization as director in Copenhagen and in Geneva, and has authored numerous healthcare policy documents in Spain and internationally. He is also a senior fellow of the Harvard School of Public Health, vice chairman of the European Commission's advisory group for Horizon 2020, looking at health, demography and well-being, and director of the health department at the Spanish Deusto Business School. He, of course, chaired the expert panel that reviewed health and social care here in Northern Ireland, and its October 2016 report, widely known, as I've said earlier, as the Bengoa Report, set out a radical blueprint for transformation of services here in the province. Without further delay, it's my absolute honour and privilege to welcome Professor Rafael Bengoa to deliver his lecture. Rafael.
Thank you very much, Vice Chancellor, and all of you for coming this afternoon. It's a pleasure and, of course, an honor to be here. It's sort of strange to have a Basque Spaniard sort of celebrating the 70 years of your NHS. But we have a sort of NHS that we developed based on yours. And since I studied in London for many years, I think I've kept in contact in general with many things in this part of the world, and of course mostly in contact with the reality here in Northern Ireland, where I had the pleasure to work with the rest of the panel and the civil service, etc., that is here today. I'm going to talk mainly about implementation, because I think the challenge we have is not where to go. I think most people decided I'll be saying 2 or 3 things, but I think I'm going to focus on implementation, what we're seeing in other places about how to move these large-scale changes forward and how to encourage and promote them, and to try and see after with the panel whether that is at all relevant for Northern Ireland, which is one of the countries, one of the regions which has decided formally to transform healthcare, which is quite important because there are only 6 or 7 countries, not even 6 countries which have taken the formal decision to transform healthcare. Most of the others are just standing still. Now, they're standing still for very different reasons in different places, but there are only 6 or 7 countries where we can learn from to see how to move this very heavy machine that we all have forward into something quite different, and that I think we all know we need. So I'll be talking for about 25 minutes. I hope that's okay, and then with the panel we have, I understand, a discussion. The demand has grown this, sorry, I just need to be looking a bit at it. That's 4%. The budget, at least in my country, is just about to grow, but it's never going to be growing like it was before. We don't know, between 1 or 3%, but it doesn't look like the budget is ever going to be, from now on, compensating the demand and this sort of demographic and chronicity drift that we have. So we know we have to do something different, and I think we all know that the system, at least in most of the countries that we're talking about, is not fit for purpose. And that it will be and should be fit for purpose and fit for the future if transformed. If not transformed, like the other countries that I've been mentioning before, then I suppose there's an acceptance of having to do some radical things in 5, 7, or 10 years, and nobody knows. But I think it's much better to have, let's say, a more planned approach as is foreseen here in Northern Ireland. We know we're in this silo logic, and all the hospitals in the world have this verticality going, and we know we have to break that, and I think many people are trying to break that within the trusts. We know silos is not what patients need today, not even in acute care, much less in chronic care with primary care hospitals, outpatients, acute, long-term rehabilitation, etc. But this is where we are because we've had, during the last 70 years here and 50 years in Spain, and in other countries, we've had this arrangement, which was okay for acute disease, but is not okay for chronic disease. And since 80% of the things which have come in through the doors of the hospital today and to primary care is related somehow to chronic diseases, it's evident that we have to make a shift to something else. The pathway a patient, the way a patient lives this arrangement is a bit like this. You've probably seen this before, but basically our family members or ourselves, when we fall ill, what we get is fragmentation. And that's okay for acute disease because one doesn't really need to be thinking about, let's say, lifelong continuity of care for an acute condition. But if 80% is now related to chronic diseases, we obviously have to do something very differently to tie this together. And just to pick up one sentence, and this is what this person says, I fall frequently. Sometimes I break something. They repair me. But I wonder why there's no plan so I don't fall again. And basically what this person is saying is I need health and social care to work together. That's what they're saying. And we have many, many stories, of course, like this. But this is what they say when they end up in the hospital bed. This is what they say. So this is not something we're pulling off yet. And we obviously have to move forward on this agenda. The general travel direction, whether one is talking about what the panel suggested here, what transforming your care said before, what the 5-year forward is basically saying in England, what the Scots say in the law in 210, what Obamacare says, etc., etc. New Zealand, this is the direction of travel. This, in general terms, is good for hospitals because hospitals are now doing some stuff that they shouldn't be doing. I think we all know that. And the important thing is not whether to write yet another report saying this is the way forward, but say, okay, how do we move in this direction? Because that's what's difficult. It's difficult politically. It's sometimes difficult technically, but we can, and a lot of people are beginning to pull it off, and that's what I think we should be discussing more and more, rather than we need integrated care, we need patient-centeredness. I think we can all assume that that's a given, and that we need to be moving into how does one change the agenda. What's very, very interesting is that we have something we didn't have 7 or 8 years ago. We have an arsenal, a management arsenal. And I use the word management purposely because it is related to the meso and macro management and micromanagement of the organization in the sense that many of these call them tools, are now being placed in one way or another. And in some sense, in some systems, all of them are being placed. And they're all, let's say, useful integrators and useful instruments to get us away from a silo arrangement, etc. But what's interesting is the massive amount of tools that we now have to do something different. So we know how to quickly set up electronic medical records. We know how to risk stratify. We know how to integrate care more and more. You'll see some examples, of course, later. We know how to empower patients. We didn't really know how to do that 10 years ago. Now we do. And are we doing it? Well, in pieces. We are moving forward in this direction. But what's interesting is that in implementation terms, one can see that the stars are aligning so that we have the tools to do something much bigger. Now, where is the spending? In part, I think many of us know the spending, but this is interesting because this is from last week, but in health affairs. But basically, the spending is coming from, this is from the US. It's not necessarily exactly the same, but I bet it is pretty similar. It's coming from 30 conditions, which are only, let's say, about 11% of all the things we're doing in medicine. And these 30 conditions in the year 2000 accounted for 13% of the spending. And now in the year, between the year 2000 and 2014, as it's grown up, they've become 42% of the spending. Now, if this granularity is interesting because we can then say, well, if that's happening within those diseases, what is actually the driver of that spending? And it's confirmed, something we knew, but it's confirmed when you dig into one disease group, cardiovascular disease or whatever, you can identify that it is demography and technology which is driving the need for change. And actually, if we learn how to manage 30 diseases, which account for 42, we can start doing something quite interesting. This is it, and I won't go into detail, but this is it, how it's broken down for cardiovascular disease. You can see here that you have a whole bunch of interventions that we do in cardiovascular disease that you can see where the spending is. And as we move forward, if we have this for those 30 diseases, then we'll be able to tackle in a much more specific way where the spending is happening and whether it should be happening there that way. And actually, it tends to tell you also, give you signals about what to do in the famous do not do, choosing wisely, right care logic of the types of things we're still doing in medicine that we know are floating between 15 or 20% of the things that don't add value. So we can identify in a much more specific way where we have to stop perhaps doing some things. Now, this slide from the Health Foundation is very revealing. It basically signals at the top curve that we shouldn't be expecting miracles from drugs or technologies. If there are, something like the hepatitis C arrangement is unlikely to happen because most of the things that are on the pipeline, what they're going to do is create more chronic diseases versus being curative. Now, the important thing is that if we discover something for, let's say, dementia or Alzheimer's disease, well, that's great, but it doesn't look like it's coming down the line. So where are we going to have an impact? It doesn't look like we're going to have a big impact in terms of the types of things we have to do on the healthcare system with cost management. You see, if we continue doing active cost management, and I think we've done that, let's say, well. But you can see that as we move forward in the next 10 years, so I'm not talking about the NHS the next 70 years, I'm just talking about the next 10 years, you can see that we've creamed what there was to cream, and we can't really expect a big impact out of that intervention. So where are the interventions? Well, in the 3 blocks in the center. The rose one is population health. We know we have to go to some sort of arrangement, population health, and the organizations that bring population health to life are accountable care systems of some type. We know we need new ways of delivering care and identify what these models are, and we know that we need to work, of course, on quality and productivity. And if those three blocks are where the biggest impact are going to be in the next 10 years, that's where we have to be attacking the issue. Now, what's frustrating and not frustrating in a medical school about this is that those things are not necessarily clinical. They're actually quite managerial. But we can't do them without the clinicians, nurses, and the rest of the health professions. So we need to be able to move forward on these agendas in order to transform healthcare in that direction, in order to increase quality and productivity. What is it that, just to continue a little bit on the tools that are, so we have this idea of what the interventions have to be, and at the same time, in that arsenal, we're beginning to have all these quite fantastic tools. The patient decision aids and the evidence behind the patient decision aids of actually working things out with patients is obviously something that has to happen very, very different to what we've been doing in the past. And we're learning how to do it, and the tools are there. This is what the Cochrane Review says about the shared decision process. We have 115 clinical trials, 35,000 participants, and a clear reduction of scheduled surgery in about 20% and improved infection rates of about 40% when you actually co-decide things with patients. If you don't get these results. So there's evidence behind some of these tools to move forward. It's not something which is generally taught in the schools, but we need to know that the evidence is saying, think in some of these ways. Now, this is the example that many of you have already perhaps seen. This is Stephen from Jogren Hospital way back, 7 or 8 years back. But it's an example of that shared decision making. Basically, he said in this hospital, Rehov Hospital in Sweden, I can do my dialysis myself, my renal dialysis myself. I don't need all this human resources, infrastructure around me. And I can do it whenever I need and I want, so I don't lose my job, so I don't lose time at job. And so the target of this hospital has now almost been reached. They're targeted 75% of the patients on renal dialysis. But the interesting things again is the results of this arrangement, which basically says you have it's something which is annoying a bit for medicine because they get better results than when we do it, and it's also cheaper. So that's not going to happen across all things in medicine, because in medicine we're going to be needing, obviously, to intervene in a structured way on patients. But actually, on some things, if we start co-producing, co-deciding with patients, I think we're going to move to new territories. In Spain, for example, in my country, nobody would have listened to Stephen. So it wouldn't have happened. I mean, nobody would have actually sat down to say, well, how could this work? So here somebody did. And then they decided to do this arrangement. This is the self-care continuum. And here I'm going to say something which is, let's say, a bit more, conflicting sometimes, but at least the population in most of the countries I know in Europe has been sort of disenfranchised from or disconnected from taking care of their own health. And that's probably the way we've built very paternalistic organizations. And so most people think about a life career, and they think about their career in job terms, but they don't think about their career path in life in health terms. And I don't want to go into victim blaming here, but I think to actually think that we're going to be able to manage that 4% demand systematically in the health system even if we transform without the population starting to take some decisions about their own health, is going to be very difficult. So I think we have to open a line of work around people taking responsibility of their own health. Now, this has been around for quite a while. We don't know how to do that as well as other things, but I think this is fairly important to say today. And there are many things that people, minor ailments and other things, are not managing when they could, and they end up in our services or in GPs when they don't need to. And so that is easy to say, but we have to make it easy for them. And so in order to advance on this, we need to be able to take decisions, and this is more at the policy level. This is a recent study again, but it still is not affordable for everybody to take decisions about their life, so about their health. It's still 3 times more expensive to get energy we need from healthy foods than from unhealthy foods. So of course that has to be changed. It's still not really understood that there are 99 cubes of sugar by many people in one of these cola drinks. It's still harder to buy healthy foods in deprived parts, in this case, of the UK. And there's also a higher density of fast food outlets in these areas. And then there's 1.2% of food advertisements spent going into vegetables when there's 22% in cakes, biscuits, and ice cream, etc. So obviously we can get the population on board to help take decisions, but at the same time, obviously we have to make that easy in policy terms, and this has to be changed in public health terms. We know then we're going to some sort of accountable care integrated system. Most of the countries which have a policy expression of wanting to do more in the community, more in primary care, more prevention, and less in hospitals, are trying, obviously, to move from managing structures to managing systems. And that's a bit, of course, the logic that was behind our report. It's also there in Delivering Together, etc. The important thing is that this journey is hard, but we have a whole bunch of tools to be able to pull it off. So I just want to talk a bit about the actual implementation process of actually going in that direction, because I think most of us are okay with some of those lines in policy, and we've been hearing them for many years. But what's really tough, what's hard, is this implementation process so that the recipients of change feel it. Now, where I think Northern Ireland is, and parts of Spain are, and Portugal is, and the US before Trump was we need more money in healthcare and social care. But that was not going to fix it, and we also need to launch a transformation. Now, as I said, there's only 6 or 7 countries who are doing that, and you're one. So despite all the difficulties that people are seeing in making this happen, there are 6 or 7 countries moving in that direction. And it's so inevitable because of the demographic and chronicity challenge we have. So where we all want to be is in more resources and transformation. You don't want to be in transformation with no resources. You don't want to be in more resources and no transformation, where a lot of European countries are. And you definitely don't want to be in no resources and no transformation. So I think because of the decisions that have been taken and transformation funds and things like that, I think you are in resources and transformation, but you have to meet the challenge of moving ahead. Now, so how does one move forward? Well, obviously, one bite at a time, because this is a very big agenda, and one has to be able to manage that change. And it's not big bang. A lot of people seem to be expecting a big bang out of either Transforming Your Care or our report or delivering together or whatever. And actually, it's not Big Bang. It's actually a very difficult move after 7 years, or actually even more years of doing something very different. So we have to know how to manage that situation. And this comes from one of the vanguards in England, but basically at the local level, this is what they're trying to pull off. It's not very clear, I'm sorry, but basically what they're saying is, look, year 1, year 2, year 3, year 4, we're going to do a few things in terms of changing the current provider landscape towards a new provider landscape from where we are. So we reduce unplanned and outpatient capacity. We try to reconfigure estates, et cetera, and workforce reconfiguration. And you can see there it's workforce flexibility, which is where we have a huge problem in Spain, because the unions are not accepting workforce flexibility. So strangely, it's in Spain, the unions are the ones that are resisting the change that we need in order to save the public system. And it's sort of a contradiction, but they're not accepting flexibility. But we need flexibility in order to then shift things to the community, in part to primary care, et cetera, doing prevention and other things that we've just talked about. But the important thing is to have a plan, one bite at a time, and to have a plan as you're moving forward on this agenda. Now, I think we all know that we need policymakers' engagement. And it's really hard for policymakers, for politicians, and this is what we've heard here and many other countries, to take these decisions about hospital reconfiguration, about shifting resources to the community, really hard to integrate health and social care. Okay, that's hard. So although this may sound simplistic, what seems to be happening in many countries is that these things which are tough, and you're trying to help politicians manage political risk, and those things are less risky. I mean, there's nothing really risky about ambitiously developing digital health. There's nothing really ambitious and difficult politically about risk stratification. Just do it. There's nothing really difficult about doing some of the patient empowerment stuff that we discussed before. There is difficulty here, and we keep on hearing, well, it's about hospital closures, etc. It isn't. None of the panel's discussions was about hospital closures. It was about hospital reconfiguration. And I think there's some element of reconfiguration that we just have to face, but we have to make that more digestible politically. And there's no magic solution or prescription on that one. Just on those over there that are less risky, just do them. Quickly set up an electronic medical record because you can do it. You have the elements to do it. And the ones that are a bit more risky, you turn into what some people call experimental government, which is basically saying, well, you launch Vanguard type of arrangements or STP type of arrangements in England, or some of the experimentations that are going on in Scotland or in Spain, etc. Now, that experimentation, the logic of that experimentation is to reduce partly the political risk by creating at a sufficient scale, not tiny scale, a sufficient scale, better results with a new model of care versus the old model of care. And that seems to be moving forward as a more accepted and less risky political arrangement than taking Big Bang solutions. So what we're trying to understand is who is actually being able to do these things and how are they pulling them off when they are. Some people have been able to pull it off, and some of you know about this experience, and I won't go into detail, but basically Canterbury in New Zealand just takes one very simple decision. There's some political risk, but they did it locally, and it's in Canterbury, and they decide we're going to have one system and one budget, and they call it like that, one system, one budget. And they launch a battery of interventions which make that possible at the provider level. They create a commissioning, if you wish, a budgeting arrangement in which you then can have the capacity at the local level to manage locally together health and social care. Now they've done it. They have a sort of NHS type of arrangement. They took a decision. Nothing's blown up politically at that level, and they're getting good results in both health and managerial terms. Firmly, NHS Trust. I'm using examples a bit more from here. I could be using other examples from Sweden or the south of Europe, but basically, they decided we're going to move from this fragmented silo to some sort of integrated care arrangement. So Frimley, for the first time in 29 years, is able to get less demand on hospitals, less emergency visits, less movement from, less derivation from primary care, and less cost by doing these things. And these things are just, let's move to the community. That's what they are. Strengthening stuff in the community. Some are more expensive, some you have to invest, district nursing, et cetera, but the cutoff point is positive in economic terms. And obviously, what is happening, and this is a bit the thinking, if you wish, the way at least I see it in Scotland, is that the final result is that you're keeping people at home. You're managing at home. And the same thing with Canterbury. Just quickly, you know the Bursar Model, but the Bursar Model of nursing is basically 12 professionals, nurses, occupying between 60, they occupy themselves between 40 and 60 people. They have to be with those people 61% of the time. They're out in the community. There are 900 teams now in the Netherlands, and it's being replicated in Kent, Suffolk, Sweden, and some parts of Spain. So a lot of people seem to be able to pull it off when it's big but local. If you try to pull it off for a whole big country like all Spain or all France or whatever, then it's much more difficult because there you're trying to say there's one size fits all versus letting things happen at the ground level. So what are the common denominators to finish off across these different transformations on different systems? Netherlands is very different from New Zealand. New Zealand is different from here, but different systems, different models, etc. What is it that they have in common? Well, they have, in implementation terms, several things in common. They embrace complexity. I like complexity, they say. So what does that mean? That means this is damn difficult, but I need to understand how to manage complexity in order to move forward. They maintain a dual focus. They manage an agenda which is about firefighting, but at the same time they're launching a transformation, let's say the more, they call it important stuff. So they can manage within complexity, they can manage ambiguity within the two agendas that they have to do. They co-develop a vision, so you have the community in those places. Birdsong is a group of nursing developing a vision. We don't like what we're doing, we're going to do something else. And they avoid scope creep. They avoid thousands of projects moving, trying to move everybody with their, they focus on what they've decided in their vision. The other thing, which is everybody in those groups have been trying actively to break silos, and they reinvented teamwork. And let me just show you an example of teamwork. It's actually quite interesting from this study from West in the King's Funds. Only in a hospital like this one here, if you only increase teamwork by 5%, you avoid 42 deaths a year. And I think we can all improve teamwork by 5%. So what these people are saying in these examples is that you have to develop a cooperative structure, and it's about teamwork, et cetera, et cetera. The other thing that they're saying, and I'll just explain very quickly, they get beyond what's called the operational disconnection, which is doctors and nurses can do their job without really following the official line from the policy level, because they just see patients and they're doing their thing. So they can live without policymakers, but policymakers and managers cannot live with them, without them. So you cannot do your managerial job without doctors and nurses and company, but they can do their job without you. And that operational disconnection has to be broken, and that's one of the things that they try to do. So you have to bring those two worlds together. And then the other thing is they determined a new leadership model, which is much more of a top-down, bottom-up rebalance, and they develop individuals and provide a context and resources for the local level, so that the local level has the capacity to fail, the capacity to experiment, the capacity to do things in an organized way. They can't fail in medicine, but they can fail in organizational and management issues. And this is just a very quick, we don't have time to go through this, but if you want to manage complexity, this is how some people in the tech world are. It's called Nass, the Nass framework. The Nass framework, I think, is a very interesting one. It's Trish Grenat is on this, but basically they're saying most of the technologies that are coming into healthcare, not the medical ones, the IT world, etc., or telehealth, and have much more difficulty in penetrating our world than others, than in whether it's banking or other sectors. And that what you need to do is to be moving 6 or 7 ways of thinking, movement that are lined up there from what condition, whether it's heart disease or whatever, what technology you're trying to, what's the value proposition, who are the adopters, what's the organizational design you need to be able to embed that technology, what's the wider system trying to pull off, and what is the embedding and the adaptation. So I don't have time to go into this, I just wanted to very quickly say there are more and more frameworks to work within complexity, and that we need to be able to understand and manage. Breaking silos. This morning, I think my sense is that I got a feeling that when you're back, when you get government back, there's going to be sufficient political consensus, as there was almost 2 years ago, to continue down this line. It would be good if they could nurture it until the government came in. But I think we have an interesting move politically here to be in. Then, of course, all the other silos one has to break. Now, just final word on the leadership model. Everything that I think just explained, there's one big decision, which is almost psychological rather than technical. It's not more expensive. It's about what Mintzberg used to call way back friendly management, so shared leadership, distributed leadership, etc., that we've all heard about. But there's some level of orchestration that you need from above on some of these things. But it seems that the people that are breaking and being successful at implementing change and transformation are more at the bottom of the organization, at the provider level, than at the top of the organization. And the role of the top of the organization is becoming clearer and clearer, and that they have to set the scene so that at the bottom they can have these relationships and can identify these new innovations. This is another way of putting it, but for other sectors, the best creative thinking happens on a company's front lines. You just need to encourage it. This has happened in all businesses. It's not happening in healthcare sufficiently. And this came out in a message from Derek Feely and Don Berwick and company. The change will have to come in from inside. If I use the Spanish example, the last 4 years and the last 6 years, all decisions have been taken by the Ministry of Finance, with a huge impact on healthcare and what was happening on everybody's lives in our NHS. So what is important is for us to make sure that the change is controlled from inside, because we're going to do a much better job than if it's done from outside. These are the things we said in the report. These are the things we said about, and I think Peter Lees last time mentioned them, but basically we just need to reinvent this clinical leadership issue. And it won't happen unless they have leeway to bring those innovations and those changes. So we need to empower those clinical leaders. If you don't remember anything I've said, just remember that most of the stuff that we probably need to do to transformation is not going to come necessarily from clinical, let's say, technology. It's not going to come from more cost containment. It's going to come from new organizations, new processes, and new quality arrangements. We are moving in that direction, and I think if you take one bite at a time, you can be one of the first countries that pulls this off. Thank you.
I think so much hope was the resonating message that came to me. What I would like to do now is to invite a number of people to join Professor Bengoa in the panel to open up a question and answer session. So get your questions ready. We're going to take them from the audience. We're going to take some coming through Facebook as well. So first of all, I'd like to invite Dr. Michael McBride, the Chief Medical Officer, to join us. Michael. Also, Dr. Anne Kilgallen, Chief Executive of the Western Trust, if you'd like to join us, Anne. And also Professor Pascal McKeown, our Dean of Medicine here at Queen's University Belfast. So, get your questions ready. I'm going to take the prerogative to ask the first one. And probably, Michael, I'll ask you as our Chief Medical Officer. We are now 2 years post Professor Bengoa's report. Where would you say we now lie in terms of the implementation of those 14 major recommendations?
Well, I suppose, I think is this working? Yep. No. Working now?
Yes, you're on now, Michael.
Okay, well, I suppose it depends who you ask, doesn't it, as ever? I think we have a tremendous tendency in Northern Ireland to downplay what we've achieved, what is working, what's working well, and we actually have a natural suspicion when it comes to individuals or organisations that are seeking to promote and celebrate what actually has been achieved. Now that serves none of us well. It certainly doesn't serve the population that we serve well, and it doesn't serve those working in the front line often in very challenging circumstances when we don't describe what it is, what we've achieved over the last period in time. Now, I'm always minded by, and I suppose it is the 70th anniversary of the Health Service, the Bevan quote, which is the health service must always be changing, it must always be improving, it must always appear inadequate, and so it will. And back to Rafa's line, we will never have a health service which is fit for purpose, but what we can do is design a health service which embeds the capacity and capability to continue to evolve, to continue to change, and to be fitter for the future and the needs of the population. So what have we achieved? Well, we have put in place some very important system enablers. So we have a collective leadership strategy, the work of Michael West, which you referenced, so important in terms of reducing mortality and improving financial control. We have a workforce strategy, which has been launched. We have important work on co-production, building on the work of PPI, which Charlotte and her team have taken forward. So really important enablers for us to work as a system. We have an elective care plan with resources to go alongside of that to improve the unacceptable waiting times that we have. We have plans for elective care centres, prototypes for those, work that's underway. We have really important and innovative work, again, which Rafa alluded to, around multidisciplinary teams in primary care, district nurses, health visitors, named professionals, social workers, wrapped around primary care teams and providing more of the joined-up services that an ageing population requires. We've seen the launch of the imaging review. We've had a consultation on the review of pathology services. All of these very important things. We've had adult social care review. Sometimes it amazes me when I listen to the media, although I try not to, or I listen to those who I think should know better, that you would think nothing has happened and nothing has changed since the publication of the report. So, I mean, the onus is on us, ultimately, to tell the story in a much more consistent, coherent and compelling way that actually inspires those working in the health service, that it inspires and builds confidence in those using the health service. And I think we have a job of work to doing that. But again, I'd be interested in Rafa's assessment in terms of how well or otherwise you think we've done in the last period of time.
Well, you did all those things.
We have.
Well, I mean, that to me is a ringing endorsement, so thanks for that. Maybe, Anne, could I switch to you now, because you're the CEO of a very, very busy trust. And in terms of the changes, what do you see needs to be prioritised so you can help deliver the better service to all of the citizens of your area?
Well, I think so. Michael has named very clearly many of the initiatives that are in hand that are really about building, strengthening the foundations that we have for change. I suppose in my organisation, what I feel most strongly is a sense of openness, willingness to experiment, willingness to identify and share good practice across the organisation. I'm a relatively new chief exec. It feels like things have always been this way. But people say to me, no, they say there is a fresh sense that we are all in this together. The strategic direction which has been set and which is reinforced time and again by the department is one of focusing on impact and focusing on working together, doing with people rather than to people. And I think increasingly staff across my organisation and other organisations have a real sense that this direction aligns with what they come to work to do. They come to work to make a difference to the people they serve, patients, service users, clients, and they work constantly in partnership with patients, with service users. So our strategic direction is so strongly aligned with what people come to work to do. And my sense is, not everywhere and not all the time, but increasingly people feel they can buy into a general movement, and a movement to do with people, to co-produce, to see waste through the eyes of the patient and the service user rather than through the eyes of the institution. And therein lies the opportunities for us to be much better into the future.
Thank you. Pascal, one final question from me. I would like to ask you, as Dean of a medical school here, and we have heard that the curriculum is being revised and changed very much to fit in with Professor Goa's recommendations. And what you are doing here in the medical school is generating the leaders of the future. So I know the new curriculum will be announced quite soon. Would you like to give us a couple of ciders of a couple of the really big ticket items that you think are going to transform medical education, which will then go on to transform our health system?
I think there's a big move away from knowledge-based economy to much more around how one applies the knowledge and shares. So we think around co-design and co-production. How do the healthcare professionals of the future manage to work with patients? And as Professor Bengoa has identified, the idea of a lot of self-care in the community. How do we empower our patients to take responsibility for health? In terms of curricular reform, I think there will be much greater emphasis on the population health. Again, one of the key themes that Professor Bengoa has identified in terms of how you transform a healthcare so that you actually try and prevent disease rather than treat patients who have acquired the disease. It's also about teamwork. I mean, healthcare is no longer delivered in a uni-professional model. It's very much around how do we deliver healthcare within teams and how do they share information. And again, I was very interested in the Netherlands model around how individuals might develop the vision and empower individuals to make a difference. As you say, Anne, the staff come to work to do a really good job every day, and I think we have to allow the staff to have that creativity to start to look at how they can influence the system rather than coming and just complaining about a system that's not working. It's about listening, sharing and innovating, I think, within a kind of a revised healthcare ecosystem.
Thank you, Pascal. So any questions from the floor? There's some roving microphones. Yes, just 5 rows behind you. Perfect. If you could just tell us who you are and your question.
Andrew Dougal. I've been involved in public health for the last 35 years. Over the last 75 years, every time there's a need for a new programme or innovation, money has been found for it. In the next 70 years, that will not be the case. I have found, even in the voluntary sector, it very difficult to persuade people to give up resources for existing programmes, to have those resources reconfigured for new programmes which are of a higher and more pressing priority? How can we begin to encourage those people to opt themselves to reconfigure those resources, to release those resources, to get their very firm grip off those resources and reconfigure them?
Yeah, I mean, thank you. A very important question, because Professor Bengoa talked about an increasing cost, but a decreasing resource. So how do you square those two circles? You must fight hard for budget, Michael, where you are. So what do you think is the future direction of travel in terms of being able to resource a health service that is fit for purpose?
Well, I'm going to steal Rafa's slide and have conversations with my colleagues in the department about the importance of population health and the need to invest in that. But all joking apart, we do fundamentally recognise that. We do recognise that we need to be doing much more in the space of preventing ill health, in supporting people to make the right decisions. You mentioned some of the challenges that we face. The fact that you don't have public transport to go travelling to some of our housing estates, where people live in splendid isolation, where they don't have a general practice, where they often have very little in the way of recreational facilities, where they have to get a bus from somewhere down a road, or indeed get a taxi and pay for a taxi, and then go and buy food and veg in supermarkets that they can ill afford. And it's actually easier and more convenient to drop into Iceland and buy frozen fruit and veg. So it's about all of those things that we need to continue to invest in, that we do need to invest in those community-based models which are asset-based, which look at what are the strengths that are already within our communities, look to our community leaders and equip them with the skills that will help support people to live longer, more productive lives. The issue about redistribution of resources, in terms of stopping doing things which aren't working as well as we would envisage, has always been a difficult one. I mean, we tend to layer on things as opposed to saying, well, actually, we've evaluated that. It isn't actually delivering the results that we anticipated for a variety of reasons. Now we need to have the courage of our conviction to say we stop it and we redirect that money to something which is actually has evidence base that is going to work. Those are challenging discussions, because again they often involve what people have been committed to for significant periods of time. They often involve people's employment, and that in itself, we know that employment is good for your health and well-being. But somehow or other, we've got to engage in those conversations, to be courageous enough to do the right thing.
Thanks, Michael. Next question. We have about 5 rows back. Who else would like to ask a question so I can just get them lined up next? We'll go over this side next. Perfect. Okay, thank you.
Hello, Evan Bates. This is to celebrate the 70 years of the NHS, so I'd like to go back to the creation of the NHS. It came initially out of the Beveridge proposals, which focused on 5 giant evils, as he put it: poverty, unemployment and bad jobs, poor housing, bad education systems, which left many people underachieving, and of course the NHS itself. Here, 70 years later, we've just gone through 10 years of austerity that has hammered the welfare state. It's hardly surprising that we're getting the consequences in the health service. But Bevan himself, what he added whenever he became Minister for Health, he wanted to see an impact. So he uniquely insisted that the NHS be centralised under public ownership. He brought all hospitals under central control, and that was unique because he wanted an impact. Also, accountability was a very big issue for him. And it wasn't some sort of smoke and mirrors type thing through commissioning or anything else.
If you could get your question, please.
Yes. Well, it's very much, what do you think Bevan would be saying about all this today? But basically, he wanted to see if there was a bedpan fell in a ward in Wales, he wanted it to sound in Westminster. Yet we seem to have the opposite, where we talk about making sure accountability doesn't get up to ministerial level. I think what's being proposed is actually a fudge. It's almost a reversal of what Bevan would have wanted. Do you agree?
Okay, thanks for that. I mean, I think it's a very long question, but really, I think in terms of the service that you're delivering now in your trust, if you think about the whole ethos of the National Health Service, do you think you're moving away from that, or actually really striving towards delivering what we want to see as a national service, Anne?
I believe that we are heart set and committed on living up to the principles of the NHS and a health service for all. I absolutely agree with you about the need for accountability. I think the challenge is in trying to control that accountability, because the system and the people within it there's such complexity. And so what I would prefer to see is a world in which we have well-defined and clear goals and accountability arrangements at every level in our systems of care, but we can free teams up to deliver and to achieve the outcomes that they've signed up to. And that's very much at the heart of the Bursar Model that Rafa described earlier. Each of those 900 teams across the Netherlands are very, very clear about the outcomes they're seeking to achieve, and very much in close communication with the people they serve and measured against that. So I believe I come to work to live up to the principles that you've described. I think the system is much more complex than it was at its initiation, and that's a fantastic thing. That's a credit to all of the people at the shoulders we stand on. We do need to have much more sensitive controls in place than would have been in place in Bevan's day, but we're here to serve, absolutely.
Thank you, Anne. Okay, a question here, and then there was a lady a few rows behind. Will be the next question, okay?
Mark Lawler, Queen's University Belfast. Northern Ireland probably has the best electronic health record in the United Kingdom in terms of its advancement, and Professor Bengoa talked a lot about data. How do we make data flow within the Northern Irish system that allows us to improve our health, improve research into health? Because at the moment we have a blockade in relation to releasing a lot of that information for the benefit both for the patient and also in research. So how do we go that next step? I think we've done extremely well in relation to the EHR. It's much better than we see in England, Scotland or Wales. But how do we then go the next step and actually make it work for us?
Maybe Professor Bengoa, because that's about generating huge amounts of data, but it's then being able to implement the knowledge that you get from that. So from your wider experience, what do you think is best practice?
Yeah, I think the best way is to use an example of what happens to a patient today here or in Bilbao or in Madrid or in Paris. When somebody starts having, for example, an emergency, the information system doesn't start going at the same time. So the system, as the patient is moving into an ambulance and things are done on that person into an ambulance, or things are done in emergency care, and even after when they're in a bed in hospital, the information system has to be moving at the same time and feeding the next people that are going to see that patient in real time. And that is beginning to be very, very possible, and people are pulling that off. So that requires interoperability among different systems so that that actually can happen. And therefore that patient is going to have a much better deal, because the next doctor, nurse, etc. is going to know what to do even before he arrives. What that means in terms of the whole system, of what you have to do in terms of the whole Northern Ireland or whatever, of course there's the big issue of confidentiality, but there's at least 10 countries in Europe that have cracked that, and there's no difficulty in confidentiality behind some of those systems. For example, in the Basque Country, everybody as an individual has access to their medical record since 7 or 8 years ago, and at any time of day, and there hasn't been one breach of confidentiality. Does that answer a bit your question?
Yeah. Michael, do you have any thoughts on that?
Yeah, I think roll out and implement our new Encompass program, which is our electronic care system. I think it will revolutionise both the intelligence that we have about individual patients, but actually how we use that to inform action. I mean, I was just thinking about your patient with the fragility fracture, but it's more than just health. It's about how we join up systems of information across the public sector. So if your 75-year-old there who fell and fractured hip was called Sharon, it's about how do we work with systems, with carers and families, with primary care, to risk stratify and identify those that are at risk of fall, building on some of the fall prevention programs that we already have, that we actually intervene in the community before those falls occur, or indeed after those falls are occurred, or how do we integrate that with local council systems to ensure that Sharon isn't out taking her bin out because she's at risk of falling, or indeed when there's bad weather forecasts, that actually we have public services and systems that are actually identifying the need to proactively ensure that Sharon isn't out slipping on her pavement because it hasn't been salted. So there are many things that I think we can by join up systems, and how we use that to inform research as well.
Thank you. This will be our last question from the floor.
Thank you. My name is Siobhan McCulloch, School of Nursing, but I'm asking this in a personal capacity, and thank you very much for today's lecture. And I'm really thinking about the policy of neoliberalism, which has led to a sort of managerial focus on care and healthcare, and that has had an impact, I think, on the culture of healthcare. What my experiences were that care delivery really has, and particularly in the acute sector, my experience was a dehumanisation, where the patient was dehumanised and compassion was lacking. And that really was because of the major pressures that people were under, both nursing, medical and the allied health professions. And really it was about the intensity of work that was expected to be delivered. So it's really around, I accept all the points that were made about leadership, and but I think that the system, because of the policy of austerity that we have had, which has been fueled by neoliberalism, and it's similar to the second last point that the second last gentleman made. And I'm wondering if you've any thoughts around that, because that would really my personal experience has been a very negative experience, probably better in the secondary care sector rather better in the primary care sector than in the secondary care sector.
Thank you. Maybe Pascal, could I turn to you, because not only are you Dean of Medicine, but you are a practicing clinical academic. So have you seen things change the way that the questioner has said over a period of time in terms of a reduced amount of compassion, I think, is what's coming across to me?
Yeah, I mean, I think there is an element of compassion fatigue where individuals feel overstretched a lot of the time, but there are initiatives ongoing in terms of how do we support our staff. Our staff are the most valuable resource that we have within the overall system. I mean, there are models, for example, the Schwartz Centre for Compassionate Care, the whole idea around Schwartz rounds, and so on, and how you build and allow individuals to respond to the emotional stress emotional distress that they find themselves in, and how we can try and assist them to deal with that. So there is some early evidence coming from things like the Schwartz round initiative to try and build and kind of reinvigorate that compassion within the wider healthcare sector. I know it's become sort of rolled out, for example, through the Marie Curie hospice system, again, where a lot of additional care, but also within the trust system. I think there's running a pilot in the Children's Hospital at the moment and in some other trusts. Be interested to hear from Michael's perspective as well.
Well, firstly, I'm sorry that was your experience, and I hope also that you took the opportunity to share your experience so that those providing the care can learn from that, because it is important where we don't measure up, that we do learn from that. I recognise the pressures that you're describing. I think those pressures will increase in a variety of different ways. I think that at a sort of macro level, as we hear of all the progress around genomics and precision medicine and the role of AI and other advances, the challenge in the future of health and social care delivery is how do we maintain all of that precision, preciseness of medicine with the personalised aspects of it, because after all, the delivery of health and social care is a very human endeavour. It's by human beings providing care and supporting other human beings, and that's a very human interaction. So it is only by the work that was alluded to by James earlier around how we embed the values, we embed the culture within our curriculum for all health professionals and managers working about ensuring that we're recruiting people with the values that are the right values for delivering the sort of healthcare that we would all expect, and that we continually support staff in maintaining that. And Pascal has touched on a number of aspects that through the rollout of Quality 2020, which is our policy for improving and maintaining the quality and experience of care, that we equip staff with the skills and with the competencies to do that. But I don't underestimate the challenge that it is to be a frontline health professional, a doctor, a nurse, a social worker, a allied health professional, trying to do your very best in the front line with the pressures that we face. And that's why this whole agenda about transformation is so crucially important. And I think you made those comments yourself, Rafa. We can't expect people in the front line to continue to do more. We need to do more to transform the system within they work, and to give them the best opportunity to give of their best in the system within which they work. I don't know, Anne, if you've...
Well, just to echo your point, I think I'm eternally optimistic that there are still better opportunities within our system to organise ourselves so that the pressure is less on the individuals. That's the first. And the second is I'm passionate about improvement and about applying improvement science in the workplace, and teams who work together to improve care using recognised tools and approaches generally do create a better place to work. So notwithstanding all that others have said, I would offer the thought that we can organise ourselves better, even in very pressurised workplaces, and the only way to do that is by allowing staff themselves the time and the space to make those improvements. And I see that on the ground in my own workplace. We could do more and more often and at greater pace, but I do think that we can improve within our own working environments.
Thank you very much. So time has beaten us. So what I would like all of us to do, to thank Professor Bengoa for an outstanding lecture, and for the panel for being very, very open and honest with all of the questions. So thank you all very much. So I just wanted to maybe just take a couple of minutes to summarise as best I could what I'd heard. And I think one of the opening remarks to me was the most important is, don't expect a revolution, it's an evolution. And we do really have to be patient in terms of how we make massive changes to our local health system. The demands on our health system, we all know, is enormous, increasing year on year, and the resource is not there to match that demand. So things have got to change. I think a lot of what we've heard is all of those thousands of men and women who work in the health service doing a tremendous job. I think I'll take that later. All of those people who are working in the health care service are doing a remarkable job for us. And generally, it is bad media news that you hear. It's not all of the fantastic things that are going on in the background. I think some of the things that Professor Bengoa talked about were breaking down silos, more teamwork. To me, that's quite low-hanging fruit, actually. That's things that can be achieved at a local level as well as an entire infrastructure. Also, there is a huge amount of good practice out there. We heard lots of examples from Sweden and so forth of how people have transformed particular parts of their health service. And I think it's incumbent upon us, it's incumbent upon the healthcare providers, the policy makers, academics, to go out there, get off this small island and look to see where things are being done and bring them back. But the hard part about bringing something back is the implementation. And the implementation is around what Michael talked about was you've got to make some really hard decisions. What do you stop? What do you change? And what do you decide that is the future way forward? And that is about leadership. And I think we do have a lot of very good leaders in our health system here in Northern Ireland. I wrote a government report a number of years ago, and I made 7 recommendations, not 14. But I do remember the Secretary of State saying to me was, those 7 recommendations will sit heavily on my shoulders because I will keep getting criticised until I implement all 7 of them. And I think it's exactly the same position that you're in now, Michael, in terms of there's a huge amount of work going on in there, but there will always be people asking and demanding more. So I think what you need to do is keep doing what you're doing, keep making the changes. Queen's University will be here to help you as much as we possibly can. Again, Professor Bengoa, thank you, fantastic lecture. It's been a pleasure hosting you.